Hello, everyone. Welcome to another Rafael Medina Subspecialty Virtual Morning Report. Happy Monday. We today have a specialty that we've never had on this platform before, and it's a topic that I'm really passionate about, and that is palliative care. I actually rotated with Dr. Malik on palliative care rotation and was part of the hospice team and the palliative care team. And I could I noticed his passion seep through all of the education, and you will notice that today. So, Dr. Malik, do you want to introduce yourself? Tell us what you do for fun, and how did you end up in palliative care, and why should people go into it?
Oh, yes. Well, thank you so much for having me, Yusuf and Umaima. I'm really happy to be here with all of you. Um, yeah, very excited for the session, and I think it's going to be a lot of fun. Palliative care, I came to it very organically. Um, I was a hospitalist for a few years. So I was a hospitalist for about 5 years, and then I ran a hospital medicine program as well in South Georgia in the United States, and loved inpatient medicine, loved hospital medicine, but through that experience had some moments, especially in smaller hospitals, more rural hospitals, where I was at the end of the line for a lot of the conversations. And so organically, some of these difficult discussions and navigating complex decisions happened very, very naturally. And I told my wife, I think I want to do a palliative fellowship one day. And when our kid was born, that was the catalyst for everything. And so we went on and went to fellowship at MD Anderson in Houston, Texas, and worked under Dr. Eduardo Barrera, who's a giant in the field of palliative medicine, and then came back to Atlanta afterwards. Atlanta's home for us. So my wife and I and our 7-year-old son are here in Atlanta now, and yeah, we're just loving it and rediscovering the city that I grew up in, but we've been away from it for a few years. So now I am faculty at Emory University School of Medicine. I work at multiple Emory hospitals, and I'm also the chief of palliative service for the Emory DeKalb operating units. So really, really enjoying the work, and very happy to be with y'all. You asked another question. What am I doing for fun right now? Okay. So a few weeks ago, I picked up Brazilian Jiu-Jitsu, and I've really been enjoying it. I think you sweat a lot, you get a great workout, and you basically pay to get your butt kicked, which is okay.
That's exactly what I did throughout residency as well.
But you get
Thank
better, but
you.
you get better.
Yeah. But thank you for joining. And then Umaima is a medical graduate from Morocco and has an excellent case prepared for us. Umaima, you want to introduce yourself and tell everyone what you've been doing for fun?
Absolutely. Hi, everyone. My name is Umaima. I'm a medical graduate from Morocco, as Yusuf said. I'm currently in New York, and I'm very honored to be the case presenter for our first ever palliative care subspecialty VMR. What I mostly do for fun these days is FaceTiming my family and my cats who are back home in Morocco, and I love taking long walks and jogging.
That sounds great. I want to FaceTime your cats as well, Umaima, one day. Uh, Umaima, the floor is yours if you want to go ahead and start with the case.
Yes, of course. So for the first aliquot, we have a 70-year-old retired engineer with a history of diabetes, hypertension, dyslipidemia, and COPD. He presents to your clinic for a routine health visit. He has a 40-pack-year smoking history and feels his COPD symptoms are worsening. He reports fatigue with minimal exertion. And after refilling his medications and ensuring he is on the optimal therapies for his COPD, you have time to begin a goals of care discussion.
So, Jimmy sounds like the first aliquot. We have a gentleman with COPD who's sounds like the COPD is slightly worsening, but we're still in clinic. So, I was wondering, how do you approach goals of care conversations in the clinic setting, and how do you explore the patient's values in clinic?
Yeah, so this is a great case because I think so far right now it sounds like we're in a pretty low stakes moment, meaning the patient is not acutely ill, they're not acutely decompensating, um, we're in a safer situation. But at the same time, this person has other comorbidities like COPD, hypertension, dyslipidemia, um, smoking. And so all these things are in the back of our mind. The approach that I like to take is, we keep a universal workup from a palliative standpoint when I see a patient like this in the clinic. And what I mean when I say a universal workup is we want to have evidence-based assessments and tools and strategies that we're using to best evaluate the patient's overall symptoms and their overall suffering needs, which is this idea of palliative care. The general idea of palliative care is it is the specialty focused on suffering, vigilantly focused on suffering of all kinds, whether it's physical suffering, emotional suffering, existential suffering. That is the purpose of palliative care, is to focus on all those things. So we're experts in symptom management. Of any kind of symptom that you can think of: pain, fatigue, nausea, shortness of breath, any kind of symptom that you can imagine. But we're also experts at navigating complex medical decision-making, meaning when we're in difficult situations, how do you navigate when all the options are difficult options? So in that kind of a situation, I approach it by, I'm sorry, somebody else speaking?
Good boy.
Oh, okay. So in those kinds of situations, I do try to approach it with a universal workup, meaning every patient that comes in, whether they're inpatient, whether they're outpatient, whether the patient's very, very sick and has minutes to hours to live, or has days to weeks, or weeks to months, or months to maybe years to live, they all get the same universal global assessment and global workup, which is evaluating things like I use validated assessment tools. One is called the Edmonton Symptom Assessment System. It's a validated symptom assessment tool where we ask about 12 to 14 symptoms on a scale from 0 to 10, 0 being no problems at all, 10 is the worst level of your symptomatology. And then we total it up and it gives us an idea of their symptoms. I also screen for delirium universally. Delirium, we'd be surprised at how often something like this is missed. Dr. Maxine Dela Cruz, who's a geriatrician and a palliative care physician, did this wonderful study on the percentage of missed delirium in the inpatient hospital setting. And shockingly, but not shockingly, we found that 61% of the time, the diagnosis of delirium was missed by the primary teams, where the palliative care team caught it. So when we say alert and oriented ×3, this is not enough. You have to have a validated delirium screening assessment tool in your back pocket. So the one that I like to use is something called the Memorial Delirium Assessment Scale. It's a globally used validated delirium assessment tool that measures delirium on a spectrum. It was developed in 1997 by Breitbart and colleagues, and it measures delirium on a scale from 0 to 30 with a score greater than equal to. The original testing tool had a score greater than equal to 13, was positive for delirium, but the new, when it was later looked at again by Dr. Eduardo Barrera and colleagues, they said a score greater than 7 is positive for delirium. So I use a delirium assessment tool, a validated tool that you have to have in your back pocket for assessing your patients. A and O ×3 is not enough anymore. Other screening tool I use is check for non-medical opioid use. What is the risk that this patient is going to use opioids in a way that wasn't intended, meaning not for physical pain? It's important because we find that in the United States, 1 in 5 patients have a risk of using opioids in a way that wasn't clinically intended. This is called non-medical opioid use, or NMOU. It is a real issue and something we have to pay attention to, because these are the patients, these are the people who have a higher risk of opioid overdose related deaths. So when we're screening these people and checking these people for this, it is not to label them or to judge them or to put them in any harm. It is to actually prevent them from harm and to reduce the risk and mitigate that risk as much as possible. So I use a opioid misuse screening tool. And the one I really like is, there's lots of tools out there for MDAT, or for delirium screening. There's tools out there for assessing non-medical opioid use risk. The one I like is called CAGE-AID. That's CAGE-AID. It's a simple tool that's used to screening for opioid misuse. And it just says 4 or 5 questions on alcohol and drug use. I also screen for last good bowel movement. I also screen for what is their opioid needs. I also check their PDMP. This is the prescription drug monitoring program. We have this here in the US to basically see what prescriptions that are things like opioids or controlled medications, what is the patient filling, and which pharmacies are they filling it at? And the prescription drug monitoring program is a wonderful database that helps keep us honest, to make sure that whatever they're getting Are we seeing whatever they're getting, wherever they're getting it at, to keep them safe and to protect them? If we find trends that are concerning, like they've filled multiple prescriptions in the last month from multiple different pharmacies or multiple different ERs or places, that may be something that's concerning, something we need to pay attention to. So I get a universal workup using universally validated assessments based on evidence. And I do that for folks, whether they're completely asymptomatic coming into the clinic, whether they're symptomatic coming into the hospital. And of course, we get a good story on their symptoms, on their what's going on with them, how they're doing, how long this has been going on, all the very good details about the symptoms. But when you give certain people assessment tools and certain people no assessment tools. So when you do this comprehensive workup for some folks and don't do it for other folks, I find that's not as helpful of a situation, because then you run the risk of profiling people, meaning some people get screened for delirium and some people do not get screened for delirium. Some people get screened for non-medical opioid use and some people do not. And profiling folks can put us at risk. This is sort of putting our biases into play. That means that we are focusing more on, maybe we feel that this person deserves a screening tool and this person doesn't deserve this screening tool for our own reasons, for our own bias or judgment. So I find these assessment tools, I trust the assessment tools. They help to guide my clinical decision making. I use them on everybody universally, regardless of which situation they're in, outpatient, inpatient, very sick, mildly sick. And I find that to be a very helpful general baseline of comprehensive symptom management to find out what they need. When they also come in because of their symptoms, maybe you feel that you might need to talk about goals of care at some point, just looking through their chart, because a lot of times you may just look through the chart and say to yourself, oh, just reading through the chart, I have an idea of what this patient is going to need. I have an idea of how sick they are. I have an idea of what could happen. But the truth is, when you see them and lay eyes and hands on them, and you're able to explore with them in a very universal way, and everybody sort of gets the same universal assessment, you're running less of a risk of profiling people. You're giving everybody the gold standard Cadillac workup. And you're more likely to catch things through the checklist, through a universal assessment and screening checklist. We have checklists in lots of different specialties and fields. Palliative care, in this situation, I use a checklist, not because I'm trying to practice cookie cutter medicine or anything like that, but we use the checklist because it's evidence-based, because it protects us. It makes sure we're not missing things that otherwise through human error we might miss or forget, or just might, slip our minds. And so this is where I think in a situation like this, whether it was a person coming in for maybe a goals of care discussion, or whether it was a person coming in for symptoms of like a cough or nausea or pain or whatever it was, or they were referred by their oncologist or their primary physician, everybody gets the same universal assessment tool, the same universal screening.
Wonderful. It sounds like you screen for all of these things, including delirium, opioid use, and so on. So for you to from that, you can infer where they are in terms of pain and where their symptoms are at, and then you can take it from there towards the goals of care conversation. So that's very helpful. Thank you.
Yes.
Back to you, Umayma.
Okay, so weeks later, the patient's condition deteriorates. He is hospitalized with severe dyspnea, requiring high-flow nasal cannula oxygen due to an oxygen saturation of 80%. Rapid COVID, RSV, flu screening came back positive for COVID-19, and his chest X-ray reveals bilateral infiltrates concerning for early ARDS.
Sounds like in the scenario, the patient got more ill rapidly from COVID-19 pneumonia, which is very familiar from like 2020, 2021, unfortunately. So I was wondering, how would you change your approach given the setting change? And do you change how you ask these questions or how you're going to pursue the goals of care conversation?
Yes, we do adjust in that first situation where a person is coming into the clinic. Seems like they're essentially having minimal symptoms or maybe no symptoms at all. And so you can really go with the universal setting, universal workup. In a situation like this, when a person comes in with symptoms, this patient has severe dyspnea to the point where he's placed on high flow nasal cannula oxygen. And we're showing, getting a further workup that's concerning, of course, for infection and infiltrates and ARDS. This is a situation where there has to be a balance of symptom management as well as the discussion of goals of care. From, some of the things that I'm saying may sound like common sense, but you would be surprised how often this is forgotten in the hospital setting. What I mean by that is maybe a person is sitting in the hospital, breathless, they're in tripod position, they're very uncomfortable, and we're sitting there going through a universal checklist of workup that we want to do and things that we want to ask them when they're in no condition to even answer these questions properly. We don't even know if they're delirious. We don't even know if they're comfortable. They clearly don't look comfortable. So this is bringing some of that common sense portion to medicine. Medicine is not a perfect science. As we know, medicine is an art. So there is science, but there is also an art and a finesse, and balancing those two is really, really important. So in this situation, the short of it, I would say, is this: when you see somebody is uncomfortable, when you see somebody is suffering, then we may not be in the best position to have big, high stakes discussions regarding goals of care. The first priority has to be of improving the symptoms. The first priority has to be of aggressive, vigilant management, both pharmacologically and non-pharmacologically, of the patient's symptoms. So when we see that they have dyspnea, of course, you want to find the underlying reason for the dyspnea, the shortness of breath. And, the evidence in the literature shows when you have a patient who is short of breath and hypoxic, then supplemental oxygen can be very helpful from a palliative standpoint. High flow oxygen can be very helpful from a palliative standpoint. These are not always interventions that can help cure or reverse a condition. These are interventions that are helping with symptoms, and they're helping with comfort and lessening the suffering. So sometimes it may sound like a small thing, but these are quality metrics. It may allow the patient to talk in more complete sentences with their loved ones and their family. It may allow them to sleep a little bit more comfortably at night and get more rest. It may allow them to engage in conversations with you of things that they would otherwise maybe be too breathless to talk about. So this aggressive symptomatic management, medical management of the symptoms, is super important to be able to get to those higher level conversations and those goals of care discussions. So I would say you cannot go into the main goals of care discussions without very, very vigilantly optimizing the physical functionality first. And so I think the high flow oxygen is very, very reasonable in this case. Supplemental oxygen is reasonable in this case. Other techniques that we use for the dyspnea or the shortness of breath in this situation might be things like, we have evidence for opioids, and opioids are beneficial for breathlessness and dyspnea. And the evidence, I'm not talking about these big, huge doses of opioids that are very, very large. I'm talking about even the small, tiny doses of opioids can be beneficial to patients from a symptom standpoint. For example, if we had liquid morphine 2 milligrams 3 times a day, it may help a patient with advanced COPD or advanced heart failure feel a little bit more comfortable, have a little bit less suffering. This may sound like a small bit of nothing. What does that matter in the long run? Well, we've just kind of shared that when it can help them have more meaningful conversations, sleep more comfortably at night, these are quality metrics. This is invaluable in those situations. So from a pharmacological standpoint, I will use opioids sometimes for breathlessness at a very low baby drop dose. And, we also have to not only palliate the patients and help with their suffering. Sometimes we also have to talk to the medical teams and relax their suffering too, because they may say, well, you're giving opioids. I worry this is going to potentially harm my patient and cause them to have respiratory failure and further distress. And the truth is, typically at these very, very low doses, even through a liquid morphine, for example, you could dose it as low as you wanted, even half of a milligram every 8 hours on a schedule to see if it helps with their breathlessness, see if it helps them feel more comfortable. Typically in 24 hours or less, they'll notice some improvement or no improvement at all. And that's where opioids can be helpful to sort of lessen that breathless sensation, that sensation like they're drowning or they're suffocating. From a non-pharmacological standpoint, we have options to help with their breathlessness. I like fan therapy. Of course, in the era of the COVID-19 pandemic, then we don't do the fan therapy in those situations like that. But if they have COPD, for example, or heart failure, for example, then a fan blowing air in the face can be a very helpful intervention and technique. We have a 2019 study out of China showing that, fan therapy can be helpful. It tricks a nerve, the trigeminal nerve, into thinking you're less breathless than you actually are, and you can get relief from that. And so, for example, if I was climbing 5 flights of stairs and I didn't have a fan on me, then I might take a minute to recover. But if I had, the 5 flights of stairs and then had a little pocket fan that I was blowing on me, I might take 30 seconds to recover. So it doesn't fix the end-stage COP. It doesn't fix the end-stage heart failure, but it might make an improvement in that breathlessness. And that is a very, very meaningful jump in quality and might allow you to have further discussions regarding goals of care. Sometimes if there's no fan at the bedside, a lot of times we don't find it, then I will take a little fan and maybe fan them off while I'm talking to them. And then you will see something amazing happen. They will start to relax a little more and calm down a little bit more. And they may be able to talk in more full sentences. So, the pharmacological and non-pharmacological techniques are very helpful to sort of getting the patient in that best position to start having big discussions. Symptoms aside, this is where the universal assessments and screening tools play a huge role as well, because A and O times 3, or alert and oriented times 3, is not a real measure of delirium. Unfortunately, because delirium is on a spectrum, you may have a person that is compensating very well, meaning they're eating their food, or they're answering some simple yes and no questions, or they're waving at the nurses as they pass by the room. But then you do a validated delirium assessment tool on them. For example, I use the Memorial Delirium Assessment Scale, and the score may be a 14, which is an abnormal score. And when you see something like that, that goes to show you that there's a spectrum to delirium. Being delirious does not mean you're intubated on pressors in the ICU, or you're completely awake and alert, doing complex algorithms in your head. No. Delirium is a spectrum. So that means that I'm not really interested in catching the person who's intubated, sedated in the ICU. I know they're delirious. My 7-year-old knows they're delirious. I care about catching the person who is awake, alert, nodding yes and no to some simple questions, but their brain is doing exactly what it's supposed to do, and it's compensating well. So they're covering it up and masking it a little bit. And like we said, remember, Dr. Dela Cruz's wonderful study said that 61% of the time, the primary teams miss the diagnosis of delirium in the inpatient setting, where the palliative team catches it. So that's the importance of having a really dedicated screening tool.
Wow, I love your advice of first make sure the patient is not having any suffering, to treat their symptoms, and then if you have room for discussion, take it from there. And I know a lot of listeners, or like in this scenario, freak out a little bit because they're like, oh, this patient might have to be intubated if I leave the hospital, if I don't have this conversation now. We're not going to miss something that the patient would want. Now, assuming the patient was in a place that they're not delirious and they are able to discuss, but they are on this nasal cannula and you're worried that they might get intubated, do you have any advice for trainees on how to approach this conversation?
Yes, and I think that when you do your screening tool and your delirium assessment, and like you're saying in this scenario, the patient is not found to be delirious. And you feel that they have medical decision-making capacity, which capacity is its own assessment on its own too. It requires these 4 pillars, which is an understanding of your situation, an appreciation for your condition, being able to rationally manipulate the information, meaning if I do this, then what will happen? If I do this, then what will happen? If I don't do this, what's going to happen? And then the 4th pillar of capacity assessment, which is a medical legal term, is communicating a clear and consistent choice. When all 4 pillars are there, the patient has capacity for medical decision-making. You've done a delirium assessment and they're not delirious. You've done a capacity assessment and they seem to have capacity. Now you can go into some of those conversations. And the way I really like to start with those conversations is I end up treating the family meeting like a procedure. So in our palliative world, in our non-palliative world, we have procedures all over in medicine, right? We have intubation as a procedure, a central line as a procedure, all types of procedures that you have. And when you have procedures, you have indications for procedures, contraindications to procedures. How do you keep a sterile technique and sterile field for the procedures? Well, in the palliative world, I look at the family meeting as our version of a procedure, meaning you have indications for a family meeting, you have contraindications for a family meeting, you have a sterile technique, a way you have the family meeting so that you have the highest chance of success as possible and the lowest risk of complications and distress points. So treating that family meeting, which is even if it's that interaction with you and the patient and maybe their loved one in the ICU, when you feel that in a few hours they may get to a point where you're needing to have a conversation about intubation, but you feel something is coming. That is a very impromptu family meeting. And the way you do it is you treat it like a procedure, meaning family meeting procedure. If the indications are that you worry that the person could decompensate soon, that's a clear indication for it. Or if you have a diagnosis, or maybe the biopsy results have come back, or you know what you're dealing with, and then indications for family meetings, contraindications for family meetings. Maybe the patient says, I don't want to talk about it. Maybe the family says, we don't want to talk about it. Maybe the workup is not complete and you don't have the biopsy in yet. And so it's hard to kind of prognosticate and give some estimates if you don't have the necessary information in from the workup. But, and then how do you keep, a sterile field during the procedure? So when we're talking about it as a family meeting, then the sterile field is making sure you're talking to the right stakeholders. Are we talking to the right decision maker? If the patient is delirious or doesn't have capacity, well, who is their medical decision maker? Is this what we call a surrogate medical decision maker, their legal next of kin? Have they ever filled out a document, a properly filled out document saying they want this person to be their legal next of kin, or they want this person to be their medical decision maker? And you sort of have to go through that. Anybody in, training will tell you we've had these situations where you're talking to a medical decision maker and you've been making lots of decisions for the patient over the last 2-3 weeks, transfusions, procedures, interventions. The patients have been getting weaker and worse over the last 2 weeks, and you've been making all these decisions through this medical decision maker, the patient's wife. And then maybe 3 weeks later, the patient's on, a breathing machine, they're on multi-pressure support. And then you find out that this is not the legal wife, this is the common law wife. And there's 4 adult children who have no idea that dad is intubated, sedated on multi-pressure support in the ICU. That is a very difficult situation. And that is a situation a lot of folks have been through, and teams find themselves feeling very, very frustrated when this comes up. But this is how important it is to make sure on the front end that you are talking to the stakeholders, you're talking to the right people and involving the right people. So when I do that family meeting, that procedure, then I make sure, number one, delirium, yes or no, capacity, yes or no. Am I talking to the right stakeholders? Do we have them in the room? Do we need to get them on the phone quickly? Once we get the right people in person or on the phone, we try to do it as quickly as possible. Then I get into the first part, which is introductions. Have you all heard of palliative care before? And if they say no, well, I'm glad to share a little bit later about what it is I do in palliative care. Or my name is Dr. Malik. I'm the ICU attending. I'd like to know who everybody in the room is or everybody on the phone is. So can everybody tell me how you all are related to the patient? And then we do proper introductions, make sure they know who we are, make sure we know who they are. And then in this procedure, we get into the next part, which is I build the agenda, not my agenda, but their agenda. And so the agenda building is, so can you tell me what is on your mind today that we can talk about? And I'm just going to make a running list. And then they may tell me something, and then I say, got it. What else is on your mind today that we can talk about? Write it down. What else is on your mind today that we can talk about? Write it down. What else? What else? What else? What else? And continue to build that list. And you have to hold space and allow these families that pausing to allow them to think and process and ask any of their questions until you have a maxed out list. If you're ever wondering how long you have to keep saying what else, it's until the family stops you, until the patient stops you, until they say, well, doctor, I can't think of anything else. Maybe if you start talking and I'll come up with more questions or things. That is the indication that you've maxed out and exhausted those questions. This is super important because what you're doing by doing this is you are not making it about you. I'm not making it about Jimmy. Now we're changing the focus and we're making the focus on the patient. You're making the focus on you first, me last, not me first, you last. This is actually an art of negotiation. There's a wonderful book called Getting to Yes that was written in 1981, and it's been revised a couple times. But Getting to Yes, an excellent book from the Harvard Negotiation Project on this idea of principled versus positional negotiations. And what I mean by that is positional negotiations are the old style of negotiating. It's let me share my position, and then you can share your position, and then I'm going to share my position again, and we'll go back and forth until we get a deal. Versus principled negotiation. This is where let me learn about your position. Let me keep almost obsessively diving into your position, into your perspective, until I really have a good understanding of your perspective. And from there, let's figure out something that helps everybody win. So positional negotiation is a me first, you last mentality of negotiating, where it's maybe one side wins and the other side loses, versus principled negotiating, which is this you first, me last mentality of why can't everybody win? I'll give a simple elementary example of this kind of negotiation. Suppose you have a patient who, or not a patient, I'm sorry, suppose you see a shop that sells lamps, and you like the lamp, and the lamp is, you go to the shopkeeper and you say, hey, that's a nice lamp. How much for the lamp? And he tells you it's $15. You say, well, how about $10? Shopkeeper says, $14. And you say, how about $11? Shopkeeper says, $13. That's my final offer. And then you say, $12.50. I can't go a dime higher than that. Sorry, take it or leave it. Shopkeeper says, I'll leave it. Deal's over. Both sides stuck to their position, dug their heels in the sand, and nothing was accomplished through that. That is an example of positional negotiation. Me first, you last mentality. Versus principally negotiating, which is a you first, me last mentality. Suppose I see that lamp in the shop on the second case, and then I like the lamp, and I say, hey, shopkeeper, that's a nice lamp. How much for the lamp? Shopkeeper tells me $15. My next question is, how'd you get to $15? Shopkeeper says, oh, well, this is it took me time to build this lamp, and the base, my brother made it, and by hand, and then my wife did the inscription on the lamp, and we imported the shape, the shade of the lamp from Morocco. So it took a lot of time to build this lamp. And then you tell the shopkeeper, wow, it looks like it was a lot of work that you put into building this lamp. And he says, yes. And you tell him, there's a shop just about a 1 minute, 2 minute walk that way. They're selling a very similar looking lamp for about $13.50. Would you be willing to match the price? The shopkeeper tells you, okay, but only if you buy the lamp right now. Deal. That is a small elementary example of principally negotiating. Your first instinct was not to go further into your position. Let me tell you my position. Your first instinct was to dive into the other perspective. How did you get to $15? That is a small example of principally negotiating. So back to the family meeting as a procedure. When you treat it like a procedure, then you look at it in that way of what else is on your mind? What else? What else? What else? Let me keep making that running list until we have exhausted your questions, your concerns, your worries. And by doing that and negotiating in that way, you will get to somewhere better. You will cut to the chase. You will actually get to the point faster. You will stop wasting everybody's time. Very, very fantastic way of negotiating. And since I've been doing this, I have never gone back to the old way, which is sort of coming in with a me first, you last mentality. I could easily go into the room and say, hey, Mr. So-and-so, here's what's happening to your body. Blah, 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 blah. 5 minutes of me talking. And then at the end, I say, that's it. That's what's going on. Any questions? And then they'll say, no questions. And I'll say, okay, great. And then I just keep going based on what I need versus me coming in with building an agenda, treating it like a procedure, asking them what's on your mind, what else, what else. Once we have built that list, now the patient and the family has set the agenda, and then we can go into the agenda that they have set, which is the most important things. But the first thing I may ask them is, final question, which is, what has the medical team told you is going on with your health? I want to make sure we're all on the same page. So I'd love to understand your understanding of what's happening with your health and your body. And then you have to pause and give some space here. This is a concept called holding space, probably one of the top 3 hardest things to do in medical school. It is harder than anything I can think of. It's harder than metabolic diseases. It's harder than, lots of different topics because it's very awkward. It's very strange to just hold space, which is this art of pausing, of saying absolutely nothing and sitting in the person's emotional space. But when you're able to do it and do it effectively, and you might feel a little awkward and weird doing it, I promise you, amazing things will happen. They may provide insight into what they're really worried about. They may therapeutically release and cry. They may be able to come up with questions that they weren't able to think about before because the medical teams are moving so fast that it doesn't give them any time to process and think, especially in a very difficult situation. So these are a few strategies and techniques I use when we need to have some sort of a discussion or a family meeting. Is, of course, we optimize physical symptomatology before we get into the goals of care discussions. But when we go into the goals of care discussions, we treat it like a procedure, meaning introduction, what's on your mind, what else, what else, what else. Make sure we are talking to the right stakeholders so we're doing it right the first time. And then from there, we can go into the things that they're really, really worried about and start having those difficult discussions. And we use specific conversational techniques to navigating those difficult discussions, which we can talk about a little bit later.
Wow, your spiel is amazing, especially the setting the agenda and going through the checklist one by one. I think we've definitely talked to the wrong family member in the past, and I noticed your approach is very different than most people in medicine who usually go in and say their agenda. But it sounds like in your perspective, you let the patient determine the agenda, which is honestly a refreshing point of view. I think that's very interesting, and I'm definitely going to use that in the future. So I hope the listeners will use it too. Umayma, back to you.
That was wonderful, Dr. Malik. Thank you so much. So back to our patient. The patient decided to remain full coat, and despite agreeing to further treatment, his condition unfortunately deteriorated in the ICU. He developed acute respiratory distress, altered mental status, and severe difficulty breathing, leading to intubation and life support. The healthcare team questions whether intensive care is appropriate given his poor prognosis, but his wife insists on full coat status, honoring his wishes.
So this is a situation I think many of us have been in before, where the patient unfortunately got more sick, and the family want to continue care, like medical care for now. I was wondering, how do you approach like your biases or the team's biases when they see this? And then, because a lot of times the team feel like the care is futile in some situations, a lot of times this clashes with the family and their hopes and their dreams. So I was wondering, how do you approach your feelings, the team's feelings about this? And are you like completely neutral, like completely caring for the family member, or do you have like an opinion of this is what should happen? And how do you talk to teams about this? Because I imagine this is difficult, and I'm sure you've encountered this before.
Yes, this is a very, unfortunately, this situation happens a lot. And it can be a very difficult situation. And the suffering is not just, of course, it's with these patients, of course, it's with their families, but the suffering is also, as you were pointing out, with these medical teams who are navigating this moral distress. And what are we doing? Are we doing something that's helpful because we took an oath to help our patients and we feel that we are doing more harm sometimes than benefit? So how do you negotiate and navigate that? These are forms of negotiation. And whether we realize it or not, we are negotiating every single day. Even that person who, cut in front of you in the car, in the lane, in traffic is a negotiation, whether you believe it or not. And so this is an example of a negotiation. How do you handle negotiation? How do you check your bias? This idea of bias is also an important piece because it tailors how you're going to approach a situation like this, where the family wants to honor the patient's wishes and continue full code status. So the ICU team may give me a call and say, Dr. Malik, we want you to consult on this patient to make them DNR. Please make them DNR, because if we do this, this patient is in a terrible situation. It's going to cause a lot of distress. We can't do this. Or, or we're consulting you to help them get it because I don't think they get it. We need you to make them get it. And so this is why we're consulting you. This happens a lot. And it's not because, it doesn't mean these teams or these doctors or these APPs, advanced practice providers, are bad people or they're saying anything bad. It's more of a, I take it as this is a manifestation and an expression of their suffering. So what they're saying to me, even if I don't agree with it, I always want to give them the benefit of the doubt, and they're suffering in some way, shape, or form. And so what they're sharing with me and saying to me is an expression and a manifestation of their suffering. And I'm talking about the medical team in this situation. We especially saw this suffering exposed during the COVID-19 pandemic. In a situation like this, the question also is, how do you align with people? How do you get to a place where you're getting to what the patient really wants? And I will use the same principles in this manner, meaning we want to put the patient first. We also want to negotiate based on principles, not on positions. So we have to dive into the person's perspective, almost obsessively learning and diving into their perspective. But we talked about that, but another important point that I think is the messaging that we give to patients and to families. And so Dr. Kimberson Tanko, who's a palliative care physician out of MD Anderson, did a wonderful study on optimistic versus pessimistic messaging. And so the question that, what he did is he had two videos that were being shown, videos of physicians who are clinicians who are giving a patient optimistic messaging or pessimistic messaging. And the people who watched these videos were patients who had advanced cancer themselves. So in the first video, the clinician was giving a more optimistic kind of messaging. I believe in you. You've got this. Don't worry. You're a fighter. I'm with you every step of the way. You're going to make it. You're going to be fine. This kind of optimistic messaging on one video. The second video had a clinician delivering more pessimistic messaging. I'm worried, things aren't looking so good. If this doesn't work, I don't know if we have any other options. If this were my mother or father, I don't think I would go in this way. Sort of a pessimistic messaging approach. And what we found was really, really interesting. I'm sure the audience is not going to be surprised at all as to which type of messaging the patients who had advanced cancer themselves, which type of messaging they preferred, optimistic versus pessimistic. I'm already going to tell you, you're completely right in that they preferred the optimistic messaging approach. But the interesting part about this study was this. What we found is that when the clinicians were delivering a messaging that was on an extreme, meaning the extreme spectrum of optimism or the extreme spectrum of pessimism, these clinicians were perceived as being less trustworthy and less knowledgeable. They were perceived as being a little shady or misleading. That is the learning point that we can take. If you are going to deliver messaging to patients in situations like this, or if you are going to talk to families about this, don't be on the extreme of optimism or extreme of pessimism. If you ever find yourself in that situation, check yourself, acknowledge your bias, and swing away from that extreme, and you will be delivering better messaging. There's another study done by Dr. Sriram Yenu, who is a geriatrician and a palliative care physician, who did this wonderful international study. And he asked patients who had advanced cancer themselves a very simple question. He said, do you think your cancer is curable? These patients were people who were on advanced cancer treatments. I'm talking about immunotherapeutics, clinical trials, these kinds of things. Any guesses? I'll give a little bit of a pause for the audience to chime in. You can type it in the chat box, but like what percentage of patients who had advanced cancer, and this was done in every continent except Antarctica, this study, what percentage of patients said, yes, my cancer is curable? I'm seeing 60%, 30%, 40%, 80%. We found that 55% of these patients felt that their cancer was curable. And they're on experiments. Let's not kid ourselves. Clinical trials are not treatments or cures. They are experiments to further future generations of cancer treatment. And what we find, though, is that 55% believe that their cancer is still curable. The first time I read this study, what came through my mind is, oh my, Jimmy, we're just terrible at messaging. We're just giving horrible messaging. We need to do better at messaging. I think there's some truth to that. We could always do better. We're always students of the game. But maybe there's something else going on here besides that. Maybe, just maybe, human beings are designed to be hopeful creatures. Maybe they're designed to be optimistic, despite what the team is telling them, despite the team is telling them how serious their condition is. Mrs. Smith, we cannot cure this. Don't you understand? There's nothing we can do about this. But even despite the messaging that they're giving them, maybe they still retain hope. And with that optimism, pessimism spectrum, what we find in another study is a 3-to-1 optimistic versus pessimistic ratio was the sweet spot for messaging. So I'm not saying that, you're going to say 3 optimistic statements to your patient and say, okay, now I said 3 nice things. Now I have to say 1 pessimistic statement. Nobody's actually thinking like that in real life. But what I am sharing with you is that the sweet spot for messaging to your patients and your families is to align with their value system, align with their hope. And the synonym for hope is optimism. But sprinkle in the reality. And I think the synonym for reality is pessimism. I'm going to share another study. There's another idea, this concept of nudging. And if you haven't heard about this concept of nudging, nudging is this idea of, it's on a spectrum as well, not optimism, pessimism, but it's on a spectrum of autonomy and paternalism. If you find yourself on either end of the spectrum, very, very autonomous, meaning what do you want to do? Mrs. Smith, do you want to get intubated? Sure. Do you want to get a 7th line of chemo? Sure. Do you want to come back into the hospital 10 times? Sure. What else? What else? You want to go back and forth ICU to medical floor? Sure. What else? What else do you want? What else do you want? What else do you want? Sort of in a mindless fashion, you're being overly autonomous for this patient. That end of the spectrum is one part. Then there's this other end of the spectrum of paternalism. Where you're saying, he's so sick. I'm telling you, if he has a code blue again, we're not going to do anything. This is useless. I wouldn't do this. Or we say, if this was my father, my mother, my brother, my sister, I would not do this anymore. So we're going to stop. I'm not going to offer anything else. I'm not going to do this thing. I'm not going to do that thing. This sort of extreme version of paternalism. If you find yourself on either end of the extreme spectrum, check yourself, acknowledge your bias, and swing away from that and go somewhere towards the middle. And I like to think that the synonym for optimism is hope, aligning with the patient's hope. And another synonym for that is autonomy, which is aligning with their value system and their autonomous desires and wishes. And the synonym for that pessimism is reality. And another synonym for that is paternalism, which is you sprinkling in that opinion. That medical professional opinion, which is what we forget sometimes to do in the medical setting. We are so used to our technological advances that we can recite everything to you. We know the ventilator settings, we know all the electrolytes, we know all the labs, all the numbers, all the data. And that's wonderful. But a lot of times they're not coming here just for the labs and the data and the number dump. They're coming here for an opinion. Doctor, medical team, what do you think is happening? They may be even showing up in the ER because the ER is sometimes unofficially the place to get your 3rd opinion or your 4th opinion. And so recognizing and being aware of that is really, really key. So when I'm negotiating with a family like this, where a family wants to honor the patient's wishes, continue full code status, I want to dive into their perspective, principle negotiating, and I'm going to align with their hopes. For example, if they say, mom wants to live, and then my next question, it would be very easy to end it from there. I'd be like, okay, mom wants to live. Got it. Keep the ventilator going, keep everything going. Just don't stop anything that you're doing. But there's another approach you can take with a little bit more exploration. The patient's family says, no, keep going. Mom wants to live. Then your next response is, can you share with me what living looks like to your mother? I would very much like to understand that better. And then you hold space and you pause, and amazing things will happen. You may hear a response like, well, living looks like, she was able to be independent. She was able to take care of the grandchildren. She was able to, go play bingo with her friends, and she just lived a good quality life. And you can align with that. So I'm understanding that she seemed quite independent, quite functional. Well, I worry with how sick she is that we may not be able to get back to that. If that were the case, then what do we do? And then I hold space again and pause and give it just 3, 4, 5, 6 seconds to breathe. And that 3 seconds, 4 seconds, 5 seconds is going to feel like an eternity. It's going to feel very uncomfortable. You're going to be itching to talk. Everybody on your team is going to want to talk. Somebody's going to want to interrupt. But I challenge you to hold space, stay quiet, pause. I promise you, amazing things will happen if you're able to do that. And if you're ever wondering how long you should be holding space, then you should be holding space until a couple things happen. Number 1, until you feel weird inside. Or number 2, until the other side starts talking. They have to talk first, and then you've held space long enough. But if you have found that you are not feeling awkward with your pauses, chances are you're talking too much. And maybe you need to find a moment to hold space and pause and dive into their perspective and give them a few seconds just to gather themselves, and maybe something amazing will happen. So that's the approach that I take it in terms of optimistic versus pessimistic messaging, autonomy versus paternalism, this 55%, this idea that, no matter what messaging you're giving, these patients are aligned, or maybe we're designed as human beings to be hopeful, innately hopeful. Kurt Richter did these studies with rats in the 1950s. In one arm of his studies, he took these rats and he would drop them into a canister, and they would swim and swim and swim until they would drown. And they died. That whole arm of rats died. The second arm of rats, he took them, dropped them in a canister. They would swim and swim and swim and swim. And just as they were about to give up and drown, picked them up out of the water for a few seconds and then dropped them back in again. They swam and swam and swam and swam. Once they got tired, that they were about to give up and drown, picked them up out of the water, dropped them back in. That arm of rats never died. Richter's conclusions from this were, maybe, even though this other arm of rats literally was pedaling through life, and even if they had just a slight few seconds of a glimmer of light out of their misery, maybe in some way, shape, or form, hope aids in survival. And so that is some of the learning points I take, and that hope aids in survival, which is why that optimistic ratio to pessimistic statements is needed, which is why autonomy versus paternalism has to be monitored, which is why if you find yourself on either extreme, check yourself, acknowledge your bias, and swing away from that extreme. And bias is not a bad thing. When somebody is telling me, oh, I'm trying to get rid of my bias, I think that's a ridiculous statement. Bias is not an evil thing. Bias is your value system. Everybody comes with their own unique, individualized value system. I'm not asking you to get rid of your value system. I am asking you to check your value system and acknowledge that you have your own way of doing things, but it may not be aligned with the patient's way, with the family's way. And if you can acknowledge that, then you can obsessively dive into their perspective, step out of your own perspective, and you will get somewhere amazing because you will be aligning with them.
Wow, what a powerful answer. And I learned this like last year that they did a study on caretakers of ICU patients, and then they surveyed them 3 months later, and they found that 50 to 80% of those caretakers developed symptoms of PTSD and anxiety and depression. And the caretakers are really going through a lot in those instances. And it's really changed my perspective, like you mentioned, to meet patients where they are. So I was wondering, in this scenario, is there anything you would tell the medical team, or how would you, this person who's calling you and telling you, please, we want this DNR. And I know providers can be biased because they think, or at least they assume that the only good outcome is like DNR, but I know where it's coming from. But what would you tell them, or how do you approach it? Do you have any advice for that?
Yes, I do think that the longer that when I was, and I recognize and empathize with this concern too, because I remember as an intern and my attending or my upper levels would say, okay, we need you to get the DNR for this patient. And you feel this immense pressure that, okay, if I have to do this, and if I can't do this in some way, shape, or form, I'm somewhat of a failure because I've failed to achieve the objective that my upper levels set for me. The longer and longer I've been going into a practice, the less and less I've even cared about getting the DNR. I don't care about it as much anymore. Now my only goal is forget all that. I'm just going to drop my agenda, throw it to the side. I'm going to obsessively dive into their agenda, to their perspective. And I think that the way you present it to the medical team actually matters. And I'll give you an example. The teams all have their own unique way of communicating, their own priorities and perspectives, their own love language, if you will. And so what's the love language of the team? The old way I used to present information to the ICU, maybe the neurocritical care ICU has consulted me on a patient who's been on a ventilator for 1+ week. They have severe brain damage and brain injury, and they worry that they may not functionally recover neurologically. And so they consult me, and the old Jimi would have seen the patient, they're intubated, talked to the family, maybe had some discussions regarding goals of care. Maybe family is undecided, nothing's changed. They still want full code status. They still want everybody to continue the comprehensive multidisciplinary vigilant workup. And that's where we're at. And so I'm literally about to go back to the team with the same messaging. So when I go back to the team and I tell them, hey, Dr. So-and-so, I saw the patient, talked to the family. We had some good discussions. They still want to continue everything aggressively that you're doing. I'll come back in a few days and check on them again. ICU attending says, okay, thank you. And then, I leave that. After a few times of doing this, I started saying to myself, Jimi, I don't know if they're really pleased with what you offered them. Because if you think about it, as a specialist, your most important person as a doctor, the most important person is your patient, hands down, no question about it. But they're not your customer. Who is your customer? Your customer is the person who is consulting you, the person who is giving you business, the person who is asking for your opinion on the patient that they're taking care of, on their patient as they're the primary team. And so you have to learn your customer's love language. And so I started changing my approach once I learned the ICU team's love language. Very, very detail-oriented, very finite, very to-do list, checklist, next steps. And so I started changing the way I package what I give to the ICU team, because I recognize that it's not just patients who suffer, it's not just families who suffer, medical teams suffer as well. And so when you don't give it to them in a package that's pleasing to them, you are actually adding to their suffering and lessening the chances that they're going to call on you again next time. So the next time I had this approach and chance for the ICU team, I started changing my packaging. They consult me for their patient. I see the patient. I talk to the family. The goals are the exact same. And so now I may tell the team, hi, Dr. So-and-so. I just had a chance to see the patient and I talked with the family. We had a good discussion. They are on the fence still. They want to continue the same vigilant, dedicated workup that the team has been doing. They feel that what you are doing is not only giving the patient the best way that they can live, but also honoring them and giving them the best version of death for them as well. So they're grateful to the team for your vigilant workup. But at the same time, they do recognize that there's a possibility that their loved one may not make it out of this, that they may not survive much longer. And so I did ask them if they would be willing to receive some information on hospice. This does not mean they're signing up for anything, just receiving information. The family said they were receptive to receiving information. So I'm going to consult our hospice representative to meet with them, provide some information. And then we agreed upon a time where I could check back in with them tomorrow, Tuesday, at 1 p.m. And so I will follow up with them at 1 p.m. after they've processed, received some hospice information, and we'll follow up on these discussions of what they want to do next. When you present it to them in that package, 100 times out of 100, the ICU team gives me the same response. Great, thank you. Yes, that's exactly what we needed. You're not necessarily giving them the answer. You're not saying, oh, I've got the DNR, it's done and it's set up for you. But what you're giving them is you're speaking to their love language and you're packaging it in a finite way of something that they can hang on to. And then you'll see them write in their note, palliative is following. They're going to follow up with the family tomorrow at 1 p.m. And then the team feels reassured. And now you are not only treating you're not palliating the patient only or the family only, now you are palliating the team as well that's consulted you. So that's one way I approach it.
We love the new Jimi's answer. I love how you give them a mission, you give the team a mission to work towards, and you ground them in honoring the patient's wishes. I think that's all our time for today. I think it's almost 1 hour. Time passed by really, really quickly. Thank you for this amazing session. Thank you, Maima. Thank you for everyone who joined. I'm going to pause the recording, and if you have any questions, you can put them in the chat, or if you have any reflections, feel free to chat right now, okay? So thank you, everyone, and hope you have a wonderful day.